Hello, my dear doctor. This is Station-05-BCC brief clinical consultation. It is written here, the scenario. This middle-aged man presented with lassitude, malaise, low mood, and low body hair. And his TSH is very low, but FT4 remains normal. So yes, my dear doctor, if you go back to the scenario, this scenario said the middle-aged man, and this man presented with the lassitude, malaise, low mood, low body hair, and TSH is very low, but the FT4 normal. Think about it. So the man presented with the lassitude and malaise. So extreme weak feeling, and all day long he feels really weak, not feeling well-being as well. And he has a low mood, depressed. He's feeling depressed, and he has got the low body hair. And according to him, that he has given the history, that he has the decreased number of the shaving. So he has got the typically loss of body hair. So if you think about the symptoms, that the lassitude and malaise, so that we can think about the ACTH axis is getting down, and low mood for depression, that the TSH axis is getting down, and the low body hair is a gonadotropin, means the LH, FSH is getting down. So these all are the pituitary hormones. So the diagnosis, the panhypopituitarism. So yes, my dear doctor, this gentleman has got the panhypopituitarism. So it's a very important case for the station 5. If you have the scenario, this scenario, before entering the room, that you need to think about, this is the panhypopituitarism, the number one case. And other than panhypopituitarism, maybe you can make the diagnosis hypothyroidism. Maybe the second diagnosis you can think about, or the low body hair, maybe the hypogonadism. So hypothyroidism, hypogonadism. So once again, whatever you made, whatever the ways, the first differential diagnosis should be the panhypopituitarism. So yes, my dear doctor, it's a very spot diagnosis before entering the room, but you need to do something else more and demonstrate some of the important features of the panhypopituitarism, so that the examiners will be impressed and you'll get the full marks in your Station 5 BCC station mining. So now listen very carefully what you need to do. So let me start by saying that the panhypopituitarism, these caused by variety of causes. So panhypopituitarism, if I'm saying, if the progressive nature of the disease or the progressive damaging of the pituitary gland that leads to the hormonal deficiencies, and that starts from the G for the growth hormone deficiency is the first. I said the G tab, my dear. G for the growth hormone deficiency, G for gonadotropin deficiency, the next one, and next one the T for TSH deficiency, and next one the A for ACTH deficiency, and last P for prolactin deficiency. What I said, my dear, the progressive nature of the pituitary gland damaging that leads to the growth hormone deficiency first, and then the gonadotropin, then TSH, then ACTH, then the prolactin. So the G tab is the mnemonics, so they can remember, my dear, altogether what the hormones deficiency getting first, then second, third, fourth, and fifth. But whenever the sudden insult or the sudden insult to the pituitary gland that leads to the first A for ACTH hormone, my dear. What I said, the sudden insult that leads to the A for ACTH, then the TSH, then later on maybe the LH and FSH. But the progressive nature that leads to the GTF, in contrast, the sudden insult starts with the ACTH first. So ACTH leads to the low ACTH leads to the low cortisol leads to the hypotension. So hypotension means the patient may present it with the hypotensive crisis or maybe the collapse. So yes, my dear doctor, what you need to do, because this gentleman having these features, the malaise, lassitude, and the low body hair, and also the low mood altogether, you need to explore all the symptoms altogether. But before exploring the things, you need to know that each and hormonal deficiency, how they are really presented. Then you need to talk a little bit further. Yes, my dear doctor, listen very carefully. This is very much important. If you start with the growth hormone deficiency, what will be the manifestations of that? You need to ask him very, very well the first question, the growth hormone deficiency, in case of children, there will be the short stature. But in case of adult, because it had adult presented to us, so he has got the different things. So the growth hormone deficiency that leads to the first one, this is very much important, the low bone mass. So the bone mineral density, bone density will be reduced, first one. And second one is really important, there is a body mass, I should say the body mass or the muscle mass will be reduced. So yes, my dear doctor, the growth hormone deficiency that leads to the single point that you need to remember, there is a bone mineral density will be low. So that's the BMD, so you can remember the B for bone mineral density, and another features, my dear, M for muscle mass will be reduced, and D for diminished sense of well-being. So the three important points that you need to remember, the BMD for the B for bone mineral density, M for muscle mass, and D for, as I said, the diminished sense of well-being. Next to the growth hormone is the gonadotropin deficiency. Gonadotropin deficiency in case of male, in case of adult people, they will have the testicular atrophy and the erectile dysfunction, and that leads to the loss of body hair. So they will be presented with the loss of libido and the erectile dysfunction and the infertility, and also they will have the loss of body hair, as well as they will have the decreased number of the shaving in case of male. And clinically, the loss of body hair and also the gynecomastia can be presented in case of gonadotropin deficiency. So in case of gonadotropin deficiency, the two important points are the loss of body hair and the gynecomastia. But listen very carefully, the gynecomastia usually a feature of the primary hypogonadism. It does mean the testicular failure, especially the Klinefelter syndrome, the most common cause of the, yes, the genetic cause that you need to know, there is a primary hypogonadism. In that case, then we can expect the gynecomastia. Gynecomastia is rare in case of secondary hypogonadism. Secondary hypogonadism means due to the pituitary failure. Until otherwise, this is replaced by the gonadotropin replacement. What I said, the gynecomastia is a feature of primary hypogonadism, and gynecomastia can be a feature of the secondary hypogonadism, means a feature of the panhypopituitarism, when the man is replaced by the gonadotropin replacement. So what we can expect in the gonadotropin deficiency, we can expect the loss of body hair and the loss of libido. So what I said, the loss of body hair, loss of libido, erectile dysfunction, and the testicular atrophy and testicular hypofunction. I shouldn't say the testicular atrophy, the testicular hypofunctioning. So the next to the growth hormone and then gonadotropin, then the TAP, T for TSH deficiency. TSH deficiency means the hypothyroidism. So very similar to the primary hypothyroidism features, my dear, very, very similar, except for the weight gain and mixed edema are not seen in secondary hypogonadism. Why? Because of the ACTH deficiency that leads to the weight loss and also no pigmentation as well. So the summary talk of the TSH deficiency means the hypothyroidism that leads to the similar pictures but will not get the weight gain and mixed edema. And next to the gonadotropins, growth hormone gonadotropins and the TSH deficiency, G, T and then A for the ACTH deficiency that leads to the hypocortisolism, and that are really very close to the primary adrenal failure, means like the Addison's disease, the typical pictures. But the two important things are not there, because the panhypopituitarism, there will be the pallor. In contrast, the Addison's disease or primary adrenal failure will have the pigmentation. Why? Because the panhypopituitarism ACTH will be arrowed down, that low ACTH leads to the low MSH, means the melanocyte stimulating hormone, that leads to the low pigmentation, means the pallor. In contrast, the adrenal gland failure that leads to the low cortisol, that leads to the high ACTH, leads to the high melanocyte stimulating hormone, MSH, that leads to the hyperpigmentation. And also, yes, the mineralocorticosteroid features are preserved in case of panhypopituitarism. In contrast, the adrenal gland failure, there will be the mineralocorticoid deficiency as well, and that leads to the mineralocorticoid deficiency features altogether. So the most important talk, a single differentiating point in the panhypopituitarism with the pallor. In contrast, the primary adrenal failure will have the pigmentation. And the last hormone is the prolactin deficiency, and this prolactin deficiency is evident by inability to lactate following delivery. However, the prolactin may be elevated if the pituitary stalk compressed and viable pituitary tissue. And beforehand, my dear, listen very carefully. You need to know what are the causes of panhypopituitarism. So yes, my dear, it's very simple. The panhypopituitarism. So the pituitary gland damaged. So yes, the pituitary gland itself can be damaged or can be pressed by the pituitary gland tumor, adenoma or malignancy, and pituitary surgery, the hypophyseectomy, and then pituitary gland radiotherapy. So pituitary gland itself and pituitary gland extra pituitary tumor, there is a craniopharyngioma. So what I say, the pituitary gland tumor, first one. And second is a sudden insult of the pituitary gland, as I said, that done by the pituitary gland or pituitary adenoma hemorrhage. There is a pituitary apoplexy and pituitary gland infarction. We call it the Sheehan syndrome. There is a postpartum hemorrhage after the postpartum hemorrhage. So what I said that very simply, the pituitary gland tumor, surgery, radiotherapy, and next second one is a sudden insult is caused by the pituitary infarction and pituitary hemorrhage. Pituitary infarction is the Sheehan syndrome after postpartum hemorrhage, and pituitary apoplexy is a pituitary hemorrhage within the pituitary adenoma. And third variety that we need to remember, that infiltrative disorders. And these infiltrative disorders may be the different varieties of disease like the hemochromatosis and also the histiocytosis X, sarcoidosis. So different infiltrative disorders that we can put them separately. So these are the panhypopituitarism, the most of the causes that we need to think about. And of course, for the station 5, the first variety, the pituitary mass and the surgery or maybe the radiotherapy, this first case may be the underlying etiology. And secondly, yes, the sudden insult, that is a postpartum hemorrhage, means the pituitary hemorrhage, and the pituitary apoplexy, and pituitary infarction after the postpartum hemorrhage, that is the Sheehan syndrome. So these two varieties that we need to remember, my dear. So provided the knowledge that we have, there is a panhypopituitarism, the G tab, there is a gonadotropin deficiency, and then the growth hormone deficiency, and the gonadotropin deficiency. Next one, the T for TSH, A for ACTH, and P for prolactin deficiency. Knowing the facts and knowing the facts of the different features and presenting features, we need to talk to our patients. You need to talk that regarding the lassitude and the malaise and the low mood as well as the low body hair. Detailed discussion will be done, but along with that, examine him some of the important features that we are expecting in a patient with a panhypopituitarism. So yes, my dear doctor, I'd like to show some of the important features that these men having some features of panhypopituitarism. So sir, I'd like to examine you, and I'd like to see especially of your body, and especially I'd like to expose your chest, your abdomen, and also to see the back and some of the examination that I need to do. So is it all right?
Yes.
All right. So thank you very much. So ideally what you need to do, you need to bring the patient back onto the couch, and then you need to examine and expose him and to show all the features that you are expecting. The most important features, my dear, number one, there is a pallor. The skin is pallor, number one. And secondly, the skin is dry, soft, and wrinkled as well. So the pallor skin and the dry, soft, and wrinkled. And thirdly, the loss of body hair. These three important features that we can see. And fourthly, there is you need to examine the genitals for the testicular volume is reduced or not, that you need to see. And along with that, if I'm saying the testicular volume, then T for tension means the postural hypertension, and third T for the temporal means the bitemporal hemianopia means the visual field defects. So what I say, the testicular, tension, and temporal. So what is that? Testicular volume, and then temporal means the testicular volume, and then T for what I said, that is the tension means the postural hypotension, and third T for the temporal means the bitemporal hemianopus. So the three T's that you need to examine, or you need to tell to your examiner that I'd like to do these things all together. Yes, my dear. So what I said, that we will show you this man has got the pallor and some of the skin changes, as I said, the soft, dry and wrinkled. And third is, as I said, that is the loss of body hair. So this man, you see the skin color. And the skin color, you see the pallor, typical pallor of the skin. And his skin has got the soft and dry. You see the dry skin. I can feel the dryness. I can feel the dryness. You need to feel the way that I'm feeling, my dear. And this is soft. You can feel the softness. Really soft. So soft, dry, a bit of wrinkled as well. You see the wrinkled here. The wrinkled skin and very soft here. Very soft. Here is also very soft. And dry and wrinkled. So in Panhypopituitarism, the skin described as a alabaster skin. What I say, the alabaster skin. It is described as a pallor and also the dry, soft and wrinkled. You can see the face of this gentleman, and also he has a really decreased number of the shaving and also loss of body hair. And loss of body hair, you can see getting down. You see here. You see here, there is no hair at all. There is no hair, no hair, no hair, no hair. You see getting down. You see on the abdomen, there is no hair. There is no hair. You see, there is no hair. So there is no hair. So loss of body hair is one of the important points that we have found in his case. Next to the loss of body hair, is very important that we need to see the gynecomastia. We need to palpate here for the gynecomastia. So he doesn't have gynecomastia. As already have talked about, that the secondary hypogonadism will know gynecomastia. Only the primary hypogonadism will have the gynecomastia. So in his case, the no gynecomastia, only the loss of body hair. You see this gentleman also, there is also no hair, only a single hair here. So here is no hair, no hair. You see getting down, you see there is no hair. So he has a loss of body hair is an important findings here for the gonadotropin deficiency. And for the thyroid axis, to see the thyroid status, at least the two important things that you need to do to feel the pulse and count it, whether he has got the bradycardia or not, for 15 seconds. So yes, he has got the rate is 76 beats per minute, so he doesn't have bradycardia. So what I'm saying, my dear, for the thyroid status, whether he has got the hypothyroid or not, that you need to see the pulse examination to see that whether he has got the bradycardia or not. Next to the bradycardia is a heart rate, is a pulse, then you need to see the reflexes, my dear. Whether he has got the bradyreflexion, means the reduced reflexes, or delayed relaxation of ankle jacks. Let's see the delayed relaxation of ankle jacks he has or not. So I need to see the reflexes with a delayed relaxation of ankle jacks, which is a classical findings of the hypothyroidism. So just stroke it here. So he has got a very good reflexes. There is no delayed relaxation. So he has got a euthyroid status right at this moment. So yes, my dear doctor, after examining him, then you need to talk regarding the concerns right at this moment. This gentleman is concerned regarding his well-being. So regarding his well-being, is not feeling well and also feeling always extremely weak and feeling lassitude and malaise all the day long, even though this gentleman is on replacement of hydrocortisone tablets he's taking, and this is an adequate replacement is going on. And secondly, he is in replacement of the thyroxine tablet. And thirdly, he is in replacement of the testosterone injection. So he is taking all the three axes all together, but even that he is feeling lassitude, malaise all the day long. And he's back, and all the hormonal test that reveals that he is within normal and within the limit of the replacement that he is taking. So now he's really concerned why, even though he's taking the three important supplements and the replacement of the hormones, but why he is feeling this kind of lassitude, malaise, and even sometimes a low mood as well. So this is really a concern. So what you need to do? So yes, my dear doctor, listen very carefully. After examining him, what we have found, and after listening his history, what we have found, definitely he has got the panhypopituitarism. So the starting from the growth hormone deficiency, and he is feeling the low well-being or feeling low well-being. This is the main concern. So what we can do, you need to tell him, sir, what I have found after examining you and also listening to your history, I found that your pituitary gland is functioning low. That leads to the varieties of the hormones getting down, that leads to all the features that you have, like your skin becomes pale and also soft, dry, and wrinkled, and you have the loss of body hair and decreased number of the shaving, and also you are having the loss of reduced libido or loss of libido, and also some of the erectile dysfunction. Even though your replacement is going on, but you're feeling a bit of lassitude, malaise, and low mood altogether. Now what we think that we need to see another hormone that we call the growth hormone deficiency, and that can be screened by the insulin-like growth factor type 1. If it is severely deficient, yes, this is recommended that the growth hormone replacement can improve the patient's well-being even after the replacement of the hydrocortisone, thyroxine, as well as the testosterone injection. So that will be the answer for him. So that will be the best answer for him, so that the management will be really adequate. So yes, my dear doctor, what you need to tell for the examiner's case, that you need to tell, sir, what I found, this gentleman has got the panhypopituitarism, evidenced by he has got the pale skin, and this pale skin also associated with the soft, dry, and wrinkled skin. And secondly, along with that I found that the loss of body hair, but I have not found the gynecomastia. And also I have found that, and I would like to examine him more to see whether he has got the postural hypotension, and then I'd like to see the testicular volume, and I'd like to also examine his visual field to see whether he has got the bitemporal hemianopia, even though he doesn't have any of the features of the visual field defect. And also maybe sometimes some patients having the pituitary mass progressing disorder that leads to the cavernous sinus syndrome, like the ophthalmoplegia as well, means the 3, 4, 5, 6 cranial nerves ophthalmoplegia. So yes, my dear doctor, what I'm saying, that you need to tell this gentleman has got the panhypopituitarism, evidenced by the pale, dry, soft, wrinkled skin, and secondly, he has got the loss of body hair, but doesn't have the gynecomastia. And I'd like to examine him more to see the postural hypertension and the testicular volume, and most importantly, the bitemporal hemianopia. That is the 3 T's that you need to remember. The first T for the tension is the postural hypotension, and T for the testicular volume, and T for the temporal, my dear. So we need to remember all them together, so that you can say that you can do them all them together. And because as I said that this gentleman is really concerned, even though adequate replacement, so why this is happening? So you can say, yes, I'd like to run a blood test, especially this is a hormonal test. The another hormone may be deficient, and if it is severely deficient, that we have seen the peoples with the growth hormone replacement, the patient feels the more and more well-being. So I'd like to see that, and your hormone specialist will see you, and he will do the best, and he will try with the new hormone replacement. Is it all right? And there's the consultation ending up there. Hello, my dear doctor. I have come forward an important case, my dear. There is a panhypopituitarism. What I said? Panhypopituitarism. Yes, my dear doctor, listen very carefully. When I say the panhypopituitarism, so the pituitary gland releasing the lots of hormones altogether, so that will be the deficient, and that will lead to the different category of the features. So yes, my dear doctor, this gentleman presented with the lassitude, malaise, low mood, and the loss of body hair. And he has got all these features altogether. Along with that, he has the typically ACTH is low and the cortisol is low, the TSH low, and the FT4, FT3 even low, and then the LH, FSH low, and the testosterone is low. So these three categories of the hormones are low, all them together. I have come for an important message altogether, my dear. So you will definitely enjoy them together. So I will listen very carefully. Whenever the pituitary gland is damaged, a slowly progressive disorder that leads to the hormones are deficient, but in a progressive manner, I should say, the G-tab. Yes, my dear, just look at here. G-tab is the order of the hormones are getting down. G-tab, what does it mean? The first hormone there is the growth hormone getting down fast, and the G for the gonadotropin hormones, the next. Means the LH and FSH is the next one. And next is the T for TSH is getting down next. And A for ACTH is getting down next. And P for prolactin is getting down next. So this is the G tab I'd like to show here so that you can understand my idea. So yes, what I said, here's the G tab. So say with me, G for growth hormone deficient fast, and then the G for gonadotropins, that is the LH and FSH, and the T for TSH, A for ACTH, and P for prolactin. Yes, my dear doctor. So what I say, so these are progressive disorders. Means a progressive disorder, the pituitary gland, what maybe some the tumor, maybe the benign tumor, or the malignancy of the tumor, all right, adenoma. So pituitary adenoma. So the progressive disorders that leads to the growth hormone fast, then the gonadotropins, then the TSH, then the ACTH, and of course then the prolactin. These are the serious. But in contrast, if the sudden insult of the pituitary gland, like the pituitary apoplexy, everybody heard about it, sudden hemorrhage within the pituitary adenoma. So pituitary hemorrhage, or maybe the pituitary infarction, the Sheehan syndrome, everybody knows about it after postpartum hemorrhage. In that case, yes, my dear doctor, listen very carefully. A for ACTH is getting down fast. This is the most important information. So this is the progressive nature of the disease, and this is the sudden insult. The ACTH will go fast, down fast, rather than the growth hormone. So if the ACTH is going down fast, that leads to the cortisol error down, and this cortisol will error down, that leads to the sodium error down, that leads to the water error down, that leads to the BP error down. Yes, my dear, this means hypotension. And the cortisol error down, that leads to the sugar error down, the hypoglycemia as well. So yes, my dear doctor, so ACTH is down, that leads to the sudden insult to the pituitary gland, that leads to the crisis. Sometimes the patient will be presented with the collapse, loss of consciousness. And next to the ACTH is TSH. In case of sudden insult to the pituitary gland, the ACTH is fast, then the TSH is getting down, then the FT4 and FT3 is getting down. So the differences in between the progressive nature and the sudden insult, progressive nature leads to G-tab. And of course the sudden means acute. Acute means ACTH, my dear, just remember. Yes, my dear doctor, this gentleman has got all the excess are replaced. Means the cortisol replacement is going on, thyroxine replacement is going on, and also the testosterone replacement is going on. And these are already adequate replacement is going on. Even then, this gentleman is having the lassitude, low mood, and loss of body hair, And his concern really is a loss of well-being. This is the most important concern by the gentleman, even though adequate replacement, all the hormones is going on. Now he's asking why? This is really concerned about this patient. So what I'm saying, my dear, listen very carefully. The most important message I have come forward. Even though the adequate replacement is going on with the cortisol, with the hydrocortisone, then thyroxine, and also the testosterone replacement, he's not feeling well. But before coming back to this answer, my dear, I'd like to show him that he has got really atypically the panhypopituitarism patients, my dear. So he has got the pallor. The skin becomes pale. Why this pallor? Because the ACTH is low, that leads to the MSH is low, means melanocyte stimulating hormone is getting low. So that's why he has the pallor. So here's the ACT is low, that's why the pallor. And his skin becomes the dry, soft and wrinkled. And next to the pallor, he has got the loss of body hair. This is very much important, my dear. And also he has got the decreased number of the shaving. So yes, so he has got the pallor, dry, wrinkled, soft skin. Along with that, he has got the loss of body hair. And we need to, the three important T that you need to see to examine, my dear. T for, yes, the testes. We need to see the testicular volume, and that definitely will be reduced. And next, the T for tension, means the postural hypotension. And third T for the temporal, means the bitemporal hemianopia, means the visual field defect. So once again, the T for the testes, T for tension, and T for temporal, means the bitemporal hemianopia. So yes, he has got the panhypopituitarism. But my dear, listen very carefully. I have come forward one of the important messages. That's the best message that I'd like to deliver to all of you guys. Even though the adequate replacement of cortisone, means the hydrocortisone, thyroxine, and the testosterone replacement, he is feeling low well-being. So yes, my dear, what is the next step? The next step, my dear, is really important, that we need to see the insulin-like growth factor type 1, which is a screening test to see whether if it is low, if it is very low even, this is recommended that the growth hormone replacement will make the patients feeling the well-being, and that will give the patients much more comfortable. Yeah, so the answer is the growth hormone replacement will have the tremendous effects in his lifestyle and in his well-being as well. So the summary talk is, my dear, even though the adequate replacement of the cortisone, the hydrocortisone, thyroxine, and the testosterone, all them together, the patient is feeling low well-being. So the answer is the growth hormone replacement. But beforehand, we need to see the growth hormone deficiency by seeing the IGF type 1, my dear. So what I say, the insulin-like growth factor type 1 is a screening test. If it is really deficient, we can replace this patient with the growth hormone replacement, and that will ease all these things together. I hope that, my dear, the summary talk, that the progressive nature of the pituitary gland that leads to the GTAP, means the G for once again the growth hormone, gonadotropins, and T for TSH, ACTH, and prolactin. In contrast, the sudden insult, means the sudden damage to the pituitary gland that leads to the ACTH fast, A for acute insult or sudden insult, the A for ACTH, and then to the TSH. And the third message that I've seen, that other than the pallor and the loss of body hair, that the three T's that you need to look for into the patient, the testicular volume, and tension, means the postural hypotension, and T for temporal hemianopia. And other than these three, the last information, the last box, my dear, as I said, the growth hormone replacement will improve the well-being, my dear. I hope that, my dear, you enjoyed. Thank you very much. Thank you once again.